So how do population disease rates impact diagnostic or screening test? How do population disease rates affect diagnostic or screening test? So let's frame it this way. Suppose we have an increase in incidence. Those are new cases of disease. We have an increase in incidence. What does that do to, listen, sensitivity? What does that do to incidence? Excuse me, incidence does what to sensitivity? Doctors have the mental fortitude to make decisions in the face of uncertainty. Life or death decisions in the face of uncertainty. That's the conversation we're having here. The math is trivial. Incidence is increasing numbers of new cases, right? So if I have a lot more new case of disease, what impact does that have on sensitivity? Well, take a look at the 2x2 table I've been working with. What would be the incidence shown in this 2x2 table? What would be the incidence shown in this 2x2 table? The answer is, please listen, there's no incidence here at all. See, a screening test is not looking at when people develop disease, it's looking at whether people have or don't have disease when the test is run. When I get a positive test, I don't know whether someone recently developed the disease or whether they've had the disease for years. There is no incidence here at all in a screening test, and therefore, what effect does increased incidence have on our screening test parameters? None. Why? There's no incidence in the table. Incidence, remember, listen, new cases is what we're focusing on. In my screening test table, my diagnostic test table, I don't know new, I just know if they have it or don't have it by the test. So, what is the effect of increased incidence on sensitivity or anything else? Nothing, because there's no incidence here at all. But how about the effect of increased prevalence? Now, prevalence, I remind you, is all the case of disease. So suppose in the population, more and more of the people have the disease. Suppose that instead of 1,000 cases of disease, we now have 10,000 cases. That would be more cases, that would be increased prevalence. What does that do to sensitivity? Well, the answer is nothing. Because although the number of people change, the ratio remains constant. See, the rule is the numbers in these two cells must sum to equal the marginal. So when I add another 0 here, I must add another 0 to these two cells. And so the sensitivity remains 85%. When the prevalence goes up or prevalence goes down, sensitivity doesn't change. And by the way, neither does specificity. Changing the marginal doesn't change the ratio. What I've just said is sensitivity and specificity will be the same in every setting. Now stop. This is good because sensitivity is going to be the same in Chicago for this test. Well, let's do it this way. Pretest probability, sensitivity, and specificity. Once you know what they are in Chicago, you also know what those numbers are going to be in Los Angeles, in Tokyo, Mumbai, Rio de Janeiro. Anywhere you go on the planet, the sensitivity and specificity will be the same. Pretest probabilities are locked. They do not change with changing circumstances, including prevalence. Let me pause and go back here to deal with the question. Incidence, we're only looking at new cases. Prevalence, we're looking at all cases. Incidence, we're looking at developing disease. Prevalence, we're looking at having disease. These 2x2 tables don't tell us anything about when people got disease. They just tell us if people have disease or not, right? So any questions about incidence have no impact on screening test parameters because there is no incidence in the table. Literally, there's no incidence there. Prevalence is in the table. So by the way, let's do that. I have 1,000 diseased people and I have 1,000 non-diseased people. What is the prevalence? I have 1,000 diseased people and 1,000 non-diseased people. What's the prevalence? Give me a percentage, please. 1,000 diseased people, 1,000 non-diseased people. 50%. In this table, half of the people are diseased. Notice I didn't look at these figures because those aren't the actual diseased people. Those are just the people we found. The actual disease or non-disease is here. Half the people diseased and half the people non-disease, right? We've decided to change the criterion by which we declare somebody has TB. Instead of looking at 2 centimeters, we're going to change it to 4 centimeters. When I change the detection of TB from 2 centimeters to 4 centimeters, what does that do to the actual number of TB cases in the population? Increase or decrease? What does it do to the actual number of TB cases in the population? Okay, please listen. This is important. There's a key point here. The answer is it doesn't change them at all. Because whether I use 2 or 4 centimeters doesn't change anybody's medical status, does it? They're still the same level of sickness that there was before. Our detection and the disease are 2 separate things. There's the test and there's reality, and they're not the same thing. And I keep coming back to this idea over and over again because it is the key idea, folks. You think screening test, diagnostic test conversation is all about that? No, it's getting you to think as a habit of mind, there's the test result, there's disease, and they're not the same thing. And ideally, we have a nice correspondence between these two, but sometimes we don't. But changing how we detect the disease does not change the number of people that have the disease, right? Changing this ratio doesn't change this number. Changing test criterion doesn't change the actual health status of people in the population. The number of people in the population have TB will be the same it always was. Our criterion for detecting simply shifted. When I change the prevalence, it has, let's try again here. When I change the prevalence, it has no impact whatsoever on pretest probabilities. No impact whatsoever on sensitivity or specificity. I say it again, sensitivity and specificity are locked, and they do not change with local circumstances. Okay, how about positive predictive value? How about positive predictive value? Well, that calculation is going to be, get the right pen, that calculation is going to be here, right? Well, folks, if prevalence goes up, what happens to positive predictive value? Your options are goes up, goes down, stays the same, or please stop asking us and just tell us. Which one of those 4 do you like? As prevalence goes up, what happens to positive predictive value? Goes up, goes down, stays the same. What do you think? Look at the data on the table. I expect you to memorize the fact. I expect you to observe the pattern before you, as all good doctors do. Yeah, it goes up. Of course it does. Because we have so many more people that have disease that have a positive test. Positive predictive value is going to go up. And by the way, negative predictive value is going to go down. As prevalence goes up, positive predictive value goes up, and negative predictive value goes down. Said differently, prevalence and positive predictive value are proportional. Prevalence and negative predictive value are inverse. You can't get to predictive value without prevalence. Question. Charu, I have in my pocket 10 coins. 1 is a dime and 9 are nickels. I reach into my pocket and I tell you I have a nickel. Do you think that's likely to be true? Yes or no? Let's do it again. I have in my pocket 10 coins. 1 is a dime and 9 is a nickel. I tell you I have a nickel when I reach in my pocket. Do you think that's likely to be true? Yes or no? Because there's a lot of nickels. When I tell you I have a nickel, it's likely to be true, right? Let's change things. I have in my pocket 9 dimes and 1 nickel. I now reach in my pocket and tell you I have a nickel. Do you think that's more or less likely to be true? I say I have a nickel. Do you think it's more or less likely to be true? When you change the prevalence, you change predictive value. When you have a lot of disease there, and I say I have a diseased person, it's simply likely to be true. If I hardly have any disease, and I say I have a non-diseased person, it's likely to be true. As prevalence increases, both the true positives and the false negatives go up, right? And so positive predictive value increases with prevalence and negative predictive value decreases. You can't get to predictive value without prevalence. Deal with the patient until they know the predictive value of the result, and you can't get to predictive value without prevalence. Of course you have to know the prevalence because you can't get to predictive value, right? Folks, there's a saying, I know you've all heard this. When you hear the hoofbeats, you should think horse, not zebra, right? Because high prevalence goes with high positive predictive value. That's all we told you. Incidence have any role in positive predictive value? Question back to you, is there any incidence in this table at all? Then clearly there's no direct connection at all. These are not just ephemeral concepts. They're absolutely clear numbers you can see. And if there's no incidence in the table, then we can't talk about the relationship of incidence within the table. There's no incidence here. Pre-test probabilities are locked. Sensitivity and specificity are the same in all circumstances. Post-test probabilities, positive, negative, predictive value, are local. They're going to change widely with local circumstances, including prevalence. Let's try a couple ways to have you think this through. I want you to picture two populations, population A and population B. Population A has a known prevalence of disease. 1 in a million people have the disease. Population B also has a known prevalence. 1 out of every 2 people have the disease. I now screen population A and population B. For population A, I get a positive. From population B, I get a positive. Quick, which positive do you believe more, A or B? Quick, which positive do you believe more, A or B? B. Since so many more people have the disease there, when I tell you I have a disease person, it's simply very likely to be the case. Again, I screen. Population A, I get a negative. Population B, I get a negative. Quick, which negative do you believe more, A or B? Since hardly anybody has the disease in A, when I tell you I have a non-disease person, it's very likely to be true, right? Don't you see? It has nothing whatsoever to do with the quality of the test. It has everything to do with the base rate in the population. Take the extreme. Everybody in B has the disease. When I tell you I have a disease person, of course I'm right. If I tell you I have a non-disease person, of course I'm wrong. At the extremes, this is clear. So all we're talking about is a probability gradient between the extremes. You can't get to predictive value without prevalence. And that means predictive value, positive, negative predictive value, can change by neighborhood. I have a colleague, practiced medicine here in Chicago, where I live, for many years on the southwest side of the city. Now, in case you don't know Chicago, southwest side of the city, that's an area that has a lot of single-family homes, a lot of families with children, fairly conservative, even religious community. He said, every time in this neighborhood, I ran a test to find out whether someone has sexually transmitted infection, and I get a positive result. I found out later I was absolutely wrong. And then he changed the location of his practice. Now he's his practice on the near north side of the city. In case you don't know Chicago, near north side, this is up along the lakeshore. This is an area that has a lot of young people, a lot of apartment dwellers, a lot of dating, multiple sexual partners, fairly large homosexual community. He said, my new location now, whenever I run a test to find out whether someone's a sexually transmitted infection and I get a positive, I find out later I'm absolutely right. It's not that the test changed, the prevalence did. When you change the prevalence, you change predictive value. Pre-test probabilities are locked. They're going to be the same in all circumstances. Post-test probabilities are local. They change dramatically with the prevalence of the area in which you're working. If you change the location of your practice, all your predictive values change. It also means that unless you have a high enough prevalence, screening is stupid. If you have very low prevalence, then every time you think you found a case, you probably didn't. Oh, and folks, you know this intuitively. You go flying someplace on an airplane here in the United States. You have to go through what we call Tsa Screening. You walk up to the screening area. You have to take off your coat and your shoes and your shirt and your underwear. You walk naked through the magnetometer. You get on the other side and you're getting your clothes back on. And as you're getting redressed, the person behind you walks to the magnetometer and an alarm goes off. And when that happens, you fall to the ground covering your head, hoping you'll survive the explosion. No, you don't. You look back annoyed that the person forgot to take the cell phone out of their back pocket. And why? Because you know the prevalence of having a bomb is so low that any positive is almost certainly a false positive. What did I tell you? Tsa screening is mathematically ridiculous. The prevalence is so low, any positive is almost certainly a false positive, right? Now you know this. You know all this in your intuitive life, and so you need to apply it to your medical practice. Unless the prevalence at a certain level, then screening is stupid. When there's a new disease in the population, physicians are terrible at identifying the disease. Why? Because they're ignorant about the disease? No, because the disease is new, the number of cases are few, positive predictive value sucks. As the disease spreads through the population, physicians get better at identifying cases of disease. Why? Well, because now you have more cases, prevalence is higher, and positive predictive value is higher. It's not about the physician being good or bad. It's simply about the mathematics of screening, right? You can't get to predictive value without prevalence. That means on a test question that asks you about positive or negative predictive value, the first thought in your head should be, where the hell is the prevalence? Without prevalence, you can't get to predictive value. This is the test issue, folks. Calculating things from the 2x2 table, that's easy. Yeah, you got to know how to do that, but that's easy. It's understanding how these different variables fit together and how they affect medical practice that makes the, well, to my mind, obvious exam question. Because if you want to walk into residency and medical practice thinking that every test result you get is correct, you're a terrible doctor. And if you just say we can't believe any test result, you're a terrible doctor too. Every test result has a certain positive or negative predictive value. That is a certain believability or non-believability. And we have to deal with the gradient of that probability. That's what the conversation is all about here, of course. Prevalence and positive predictive value are proportional. Prevalence and negative predictive value are inverse. As prevalence increases, positive predictive value goes up and negative predictive value goes down. As prevalence decreases, positive predictive value goes down and negative predictive value goes up. You can't get to predictive value without prevalence. Sensitivity and specificity, the pretest probabilities, how we select a test, they are locked. And they're going to be the same in every circumstances. The test you're going to select in Utah is the same test you're going to select in Florida. Positive, negative predictive value, well, that's going to depend on local rates of disease, prevalence. Notice there's no incidence here at all in the conversation because there's no incidence in the table. There is no incidence to be had here. I want to pause. What I've just gone over is core issues for dealing with screening and diagnostic tests, not just indeed for step 1, step 2, step 3 exam, but indeed for medical practice. What is gold standard? When I use the phrase gold standard, I mean basically the expensive, prolonged laboratory test that is the best standard for saying when someone has or doesn't have disease, as compared to the test, which is the clinical thing we use, usually in a setting where we're trying to get results quickly. And the correspondence between the clinical test and the gold standard is what the 2x2 table is all about. I decide whether somebody has Down's syndrome. I have a checklist that tells me by what I observe, positive or negative, that they have Down syndrome. The gold standard would be, of course, the genetic test. But I often don't have to run the genetic test because I can make the pretty good diagnosis based on the observable data that I see. Gold standard would be the genetic test. The clinical information available before me is my positive or negative test result. What's the effective incidence on positive and negative predictive value? Here we go, nothing. Why don't we use the gold standard? How long would you like me to wait before I tell you what this person's diagnosis is? Often those lab tests might take, geez, by the time you culture the pathogen, by the time you run the test, might take days, weeks, even months until we get the result, yes? How long do you want to wait before you treat your patient? A month? Don't you think getting information now quickly would be better? Of course it is. Hence, clinical test backed up by gold standard laboratory test, but you're going to make your decision based on the clinical test. There's no effective incidence on positive and negative predictive value because there's no incidence in the table. No effective incidence on positive and negative predictive value, no effective because there's no incidence in the table. There is effective prevalence on positive and negative predictive value, but not on prevalence and sensitivity and specificity.